Why is it saying that I need permission from the host?
Good morning, everyone, and welcome to Karen's 8th Annual Addiction Research Symposium. It's a pleasure to have you all here. We're excited to bring you this event. I'm going to go off script just a little bit, but they got a great script here. My name is John Driscoll. I'm the new president and CEO of the Karen Foundation, fresh off the farm, been here a week and a half, so still trying to figure some things out, but it's my pleasure. We're excited to bring you this event both in person and virtually. Let's give a wave of those of us in the auditorium to our friends who have joined us from around the country. I'd like to thank Dr. Aaron Deneke and Dr. Ming Wang and Dr. Adams Scioli, Julie Flannery, and the entire research team for making this event possible. As I close out my second week, I think it's appropriate that this event is happening today. Karen is a mission-driven organization. Our mission of recovery for life isn't just about treatment and recovery support. It's about creating hope. And I spoke to the employees this past week a lot about hope and its creation, but also of helping of individuals, importantly families and communities to beat this disease. And the truth is, we could have had the best treatment in the world, and we do, and the best recovery support, which we will, and the best alumni network, and that without a doubt we do, but without better understanding about this disease and new treatments, recovery for life will not be possible. That's where the research we do at Karen comes in. We know so much more about this disease than when I started in this field over 30 years ago. Our treatment and understanding of this disease has evolved and incorporated science and medicines in ways that we didn't think was possible 30 years ago. Yet for many who struggle with substance use disorder, much of the treatment available is centered on what we thought we knew so long ago. And I don't know about you, but if I had heart disease, I want diagnostics and treatment that we have today, not what they would have treated me with in the 70s or 80s. That's why it's exciting for Karen. Not only has our Fran and Doug Tiemann Center for Research, but this symposium. That's why we do this, so that we can share ideas and talk about where addiction care and research is going. And what I've learned is that there's a lot of questions we still need to ask. And it's so very important, the work that we do in research and partner with those researchers across the entire country. I do need to acknowledge a couple of individuals. We have our Chief Development Officer, Sean Lavelle, in the back of the room. I myself am just here for a little bit of a morning, but the show has to move on. You've got a very busy day. And so I'm really going to let you run with this, and I've got to go do a whole bunch of new orientation things. So please enjoy your day. I would like to introduce Dr. Aaron Deneke, Senior Director of Research here at Karen, and your moderator for today's program. Thank you for being with us both virtually and in person. And please enjoy Karen's 8th Annual Addiction Research Symposium. And with that, I'll hand it over to Aaron. Thanks so much. Have a great day.
Thank you, John. And we are pleased to have you at the symposium. I know they're keeping you busy here today, as well as being our new leader and taking the mantle here at Caron. My name, as John said before, is Dr. Aaron Denicky. I am the Senior Director of Research here at Caron Treatment Centers, and I've been here almost 17 years now. So it's my pleasure to welcome you to our 8th annual Addiction Research Symposium. It's an event that's near and dear to my heart. We've had a lot of incredible speakers over the years, and we have a lot of great speakers lined up for you today. I need to make a note that I have no relevant financial disclosures. So next slide. For nearly 70 years, Caron Treatment Centers has been an internationally recognized and nonprofit dedicated to addiction, behavioral health care, treatment, research, prevention, and addiction medicine education. Caron has residential treatment centers in both Pennsylvania and Florida, as well as outpatient programs in Pennsylvania, New York, Atlanta, and Florida. At each residential location, we have full-time Caron-employed physicians on our medical team that have specialties ranging from psychiatry, internal medicine, anesthesiology, and family medicine. It is important for us to utilize the latest treatment methodologies, including neurofeedback, cognitive processing therapy, EMDR, dialectical behavioral therapy, and medication-assisted treatment, to just name a few. Excuse me. We treat our patients based on age, gender, and gender identity, profession, and treatment experiences. Caron, Pennsylvania is made up of several different treatment communities. Young adult and adult programs are primary treatment for those 18 and over, and they're grouped by age and gender. Relapse programs are for those who have had previous treatment experiences, have an understanding of the 12 steps or mutual aid groups, but find themselves continuing to use or on the verge of reuse. Grandview is for professionals and executives that need connectivity to work or professional obligations and require a private, smaller setting for increased anonymity and comfort. The older adult program is typically for those 55 and over who have significant medical comorbidities along with substance use disorder. Our newly opened PHP, it opened in June this year, allows patients to step down into a lower level of care while continuing in Caron's clinical services with supportive housing. Medication withdrawal management services are available for all of these programs. Additionally, our specialty tracks include LGBTQIA+, legal professionals, and chronic pain. I'm excited to share with you Caron, Florida's new medical center, the Keel Center, a 100,000 square foot medical center that opened this past February. It offers medication management withdrawal, older adult programming, neuropsychological services, and expanded Ocean Drive residential programming. We've moved all of Caron, Florida clinical services into the Keel Center at this time, including mental health and Renaissance treatment communities, which helps with our continuity of care for both patients and clinical staff. Caron, Florida is made up of several different communities, including Renaissance, a long-term clinically intensive treatment program, the mental health program, which celebrated 1 year this past year in August. These patients receive care in their own small, integrated, evidence-based treatment community focused on mental, spiritual, and physical health. Excuse me, Ocean Drive, which has both a residential and a PHP program, treats patients of influence and affluence. They typically require complete discretion in treatment, intensive work on relationships, and a community that understands the unique challenges for this peer group. Our highly successful older adult program opened at Keel, offering services for those who are medically compromised. And lastly, the Keel Center holds Florida's first medication management withdrawal program, allowing patients to start and complete treatment under the Caron umbrella. Within the Caron continuum, we offer a customizable length of stay that allow us to treat a multitude of addiction, behavioral health, and mental health needs. We understand and invest in the importance of research in the field of addiction medicine. This is a cornerstone of Caron and the treatment we provide. which has led to the opening of the Fran and Doug Tiemann Center for Research last year on the Karen, Pennsylvania campus. Happy to give anybody who'd like to see it after the program a tour. And you can see the listing of our current research projects here. And you can see we're quite busy. The Addiction Medicine Fellowship at Karen Treatment Centers and Tower Health Systems Reading Hospital offers rigorous advanced training in addiction medicine for physicians. It has earned accreditation with commendation from the Accreditation Council for Graduate Medical Education, signifying its caliber of meeting the gold standard in physician education in addiction medicine. Additionally, our academic affiliations and medical partnerships include Penn State College of Medicine, Drexel College of Medicine, and Tower Health System. So just a few housekeeping items before we get started. This session is being conducted both live and in webinar format. For those who are signed in virtually, please know that all participants' videos will be turned off and microphones will be muted. We encourage you to interact with us by asking questions using the question and answer feature, and we have allotted time at the end of the presentation to answer all your questions. If for some reason we cannot get to your questions, we will have someone from our team follow up with you to try to get you those answers. Today's session is worth 5 AMA PRA Credit 1, Category 1 credits, and 5 APA Continuing Education credits. We want to thank the American Society of Addiction Medicine and CEGO for partnering with us to offer these credits. In order to receive these credits, as I'm sure everybody knows, you need to complete the post-event evaluation on your CEGO dashboard. And upon completion of the evaluation, your certificate of completion will be available, immediately available. Additionally, the recording of this symposium and the PowerPoints that are presented will be available within 25 business days and will be emailed out to all the registrants. It's important to note that for attendees, you must be in attendance in person or virtually for the entirety of each session to receive your credits. For those of you who know APA, they are a major stickler about that kind of thing. For our virtual friends, each of your sessions has a timestamp to track attendance. Now I'd like to welcome today's first speakers, Dr. Ming Wang and Sharon Matthew. Dr. Wang is the Associate Medical Director of Karen Treatment Centers. He's an addiction medicine physician and is board certified in anesthesiology. Dr. Wang oversees the medication withdrawal management unit and the chronic pain programs, as well as Karen's nursing staff. He also serves as the medical director for the Grandview and older adult programs. Sharon Matthews is a licensed professional counselor, a certified clinical supervisor, an advanced relapse prevention specialist, a certified sex addiction and multiple addiction therapist, and a Rainbow Advocate counselor. Sharon was employed at Karen Treatment Centers for over 25 years. So awesome. At which time she oversaw several different programs and developed Karen's older adult program. She is currently a consultant for Karen. Welcome, Sharon and Dr. Wang.
Thank you so much, Dr. Denicky, and certainly Julie for all your hard work and the whole team that put this together. And welcome to everyone who's in attendance. And I see some old friends that it's great to see here. Nice to be back on the campus. I don't get here that often. I do a lot of consulting via Zoom or whatever, but this topic that we're going to do today is near and dear to my heart. And I know Dr. Wang's, and we were just talking recently. Is this supposed to advance? We were talking recently about developing that program in 2015, and things certainly have taken off since there. And we've learned a whole lot more about how to treat older adults and the epidemic that we're talking about of the increased use of substance use and abuse. So what we're going to have you hopefully understand is that it is the fastest growing population for drug and alcohol care. To understand the components necessary. I always say all programs are interdisciplinary, but this one really, really is and needs to be. It has to be very interactive with all disciplines because there's so much complication sometimes with the cases. We also want to look at the contributing factors. There are contributing factors such as chronic pain and trauma that fuel someone to use a substance. I know we treated many people who had never had a substance use problem prior, and then through chronic pain or the new traumas and not resolving old traumas, that could fuel someone's use. And we want to understand the course of treatment for older adults. It has to be slow, steady pace, and all disciplines, as I said, have to be consistent. So by 2050, it is estimated that there are going to be 89 million older adults, and they're looking at 65 on up. And that has increased tremendously. And it also shows that people are living longer, and especially because of the increased better medical care that people are receiving. So this is an older statistic, but I think it's important to look at the fact that years ago, older adults were not being admitted to treatment centers. It says in 1992, only like 50 were admitted to a treatment center. Then it went to 12.2 in 2008. That has certainly jumped. I know when I had left full time here in 2021, we had at that point from 2015 treated 780 older adults. And I'm very happy to say that. And it was so needed. And I think that's what I'm seeing across the board. I help at Kiel as well. And as people are coming into treatment, especially older adults, they are absolutely sicker. We say that all the time, but I really mean that they are extremely compromised. So it's really important to have the components of treatment that they need. Of course, alcohol has always been the #1 drug of choice and still is, but then people are also using illicit drugs, cocaine, sometimes a lot of marijuana, sometimes for a chronic pain condition, and then legal prescription medications. There's a statistic that says 1.3% of the population are all using prescription drugs, but then 2.3% are using over-the-counter medications, and they mix their drugs. That's the unfortunate part. They're taking this or this, and the doctor prescribes this. We always say they follow whatever the doctors and the men in the white coats tell them. So a doctor prescribed, it can't be bad for me. Opiates and benzos, what I noticed also that benzos really are running second now to alcohol. They even almost superseded the opiates in their use. So how are we going to react? There's going to be more boomers and seniors in the United States than children in the next several years. They are living with multiple chronic pain conditions, chronic pain being one of them, cardiovascular disease, other types of medical conditions. And then for the next 6 years, older adults are going to be turning 65 at a rate of 10,000 a day. That's a lot of folks. And I did see a recent statistic. There are 55 million older adults in the United States, and 4.4 of those, 4.4 million, meet the criteria for substance use or abuse disorder. So that's a whole lot of people, and I always say get your doors open, get them ready, get your treatment component ready, because they are out there and very much in dire need of treatment. So at-risk drinking is a problem in this class. At-risk drinking, maybe less than 3 drinks and maybe less than 7, but it also states that an older adult probably shouldn't be drinking more than 7 drinks a week. And it creates other problems. Dr. Wang is going to talk at length about the medical complications that arise from that. But then late onset problems, what we saw is there are a lot of people functioning until something happens later on in life. It could be retirement, too much time on your hands. It could be other stressors. It could be the loss of a loved one. It could be the loss of purpose, or it could be the loss of mobility if someone does have a chronic pain condition. So at age 50 on up, the national survey a long time ago was 12.2 were heavy drinkers and 3.2 were binge drinkers, and then the 1.8 used illicit drugs. I think that certainly has increased over time. And more older adults certainly don't look at their alcohol as a problem. And I've seen denial in people, but there's really entrenched denial in an older adult population. They have had more years to develop that defense mechanism system, number one. Families as well. Families, I've treated a lot of families as well, but this type of family system, they are so tied into this person. They don't know what to do. They don't know how to intervene on it, so they too go into their own type of denial. And then also, many older adults do not seek help. And what causes them maybe to seek help would be a fall, going to the hospital for some kind of condition that they just don't know. I also have on here somewhere that it's really difficult to assess what's going on. Doctors sometimes miss it, and not because they're not equipped to do their jobs. It's just that older adults are definitely underreporters. Older adults will not tell you or might not remember exactly what was being used, that's for sure. And they usually at this point are not using to be happy. There is no, I always tell them when they came to treatment, things weren't going good. You weren't having happy days. I love how older adults sometimes will say, well, I was doing it for the taste. Well, I think that is out the window as well. So it is proven that more and more older adults are using more and more types of substances. So the integrated model has to be looking at the physical aspect, the emotional aspect, the spiritual, mental, recreational, nutritional, and social system, and also the caregivers. We cannot forget to bring in the caregivers. And it's absolutely a population that demands respect and a non-confrontational approach. They will not tolerate you confronting their denial. You have to absolutely walk alongside them. And I always say, get them to tell their story. If you get them to tell their story, they will tell you the truth. They will tell you what has gone on, but not if you come at them. They will close down. I know I did an intervention recently, and he was so shut off from everything that the kids were trying to say. They wrote heartfelt letters. The wife, they had tolerated his drinking for years and years and years. And he basically at that point couldn't really hear them because his walls were up. However, after a day of not doing well and going out and drinking one more time, he showed up at the door and the wife took him to treatment, which was awesome. So those are the types of things that you will see oftentimes with an older adult. They're extremely vulnerable. I know Dr. Wang is going to talk at length about that, so I don't want to get into much of that point because he knows the ins and outs. I have been very blessed to be walking and working alongside Dr. Wang, who is an expert in this area. And I would say the thing we always started with was make it safe. It has to first be safe, and you must always, always start these disciplines with medical. It has to be a safe withdrawal. It has to be that their mobility is good to go. And then also what we saw a lot of is very poor cognition. And at that point, you don't know if it's age-related memory loss. You do not know if it's cognitive issues that are permanent. You don't know if it's the start of dementia. So that also takes time. So we're blessed with Dr. Daughtry here in Pennsylvania, who does assessments early on and then later on to sift out and see what's really going on. So these are the types of complications you'll see if someone is using, and it says addiction, but I just want to say abuse as well. So if someone as an older adult is abusing and using or chemically dependent, it could show up like sleep complications, isolation, health complications, your decline in ADLs, unexplained bruises, falls for sure, medication complications. And then when we look at the disease concept, chronic, progressive, and left untreated, fatal, that is the depths of denial, and I always say the level of denial equals the level of sickness. So the sicker people were or are, that is how we know how much denial they're in. Definitely, as I said, memory loss, malnutrition, oftentimes people are drinking their calories and not really eating. Incontinence happens, decline in social interaction, vision problems, decline in cognition, and hearing problems. All of that shows up. And at that point, maybe you don't know that a chemical is interfering in all that as well. Nope. So the stages of treatment are, of course, we have to identify it. Older adults are, as I said, reluctant to come into treatment. So oftentimes the use of an interventionist is really, really helpful and needed because the families do not know how to proceed. Some do go to hospitals first and then are referred here to treatment or into another treatment center. Then you go through the treatment, which is a slow, steady pace, as I said. And then the really key and the important part, which takes quite a long time, is the aftercare planning. The aftercare for this population has to absolutely be individualized. There's a slide later on as to what that would look like. And then, as I said, we developed this program with a safe, small setting, self-contained geriatric specialists. We all got trained in what it's like to work with older adults, expert nursing staff, spiritual counseling absolutely needed. There is so much grief and loss with this population, and it is, again, not the loss of a loved one necessarily, but it could be. And then what we saw with retirement, people had no longer a purpose. I don't know what, I was my job. I did that really well. Now what? Now what's next? Too much time on their hands and idle time, and then they distract themselves with drugs or alcohol. So patient-centered, using nutritionists, cognition as well, that has to be worked on throughout treatment, assessing their fall risks. And I put on here more tools in the toolbox. I really believe that wholeheartedly. Older adults like certain approaches. DBT is an excellent treatment process for them, as well as I said before, reality therapy, but they really, really respond well to experiential work as well. Stages of treatment, group versus individual. Most likely in groups, they are not going to spill everything out. They are very leery. They are very sometimes shame-based. And they have been taught at the, throughout their lives oftentimes to not share or let it out. So they stuff that. So they will oftentimes tell you a lot more in individual sessions. And when we do impact letters, when the family writes those, never try to do that in group therapy, because they will absolutely be angry and dislike you very much for it. I've had that happen to me. So you, again, bring that. And then if they would like to share with their peers, oh, well, my family's really upset. I guess I did cause some issues in the family. They might openly then talk about it. Some older adults do have addiction interaction disorders, such as gambling, relationships. If they're still working, it could also be workaholism. And then again, the level of care is really important. And our mantra did become purpose and quality of life. So I want to turn it now over to Dr. Wang. He has a wealth of information to give you, and then I'll come on at the end to tie things up. But I really want to impart on you that this population is in desperate need of help. And with 4.4 million folks out there who are in need of treatment, I hope we can all be ready for that. Okay, Dr. Wang.
Good morning, everyone. And welcome, welcome to Karen. Now, my portion of the presentation, I want to apologize ahead of time if it's too dry, okay? And to talk about a successful treatment of older adults, we have to talk about some of this, unfortunately, okay? Sharon talked about the initial phases of identifying an older adult with addiction issues and referral to treatment. Now, a number of years ago, Sharon and I came up with those, okay? Because in this industry, treating older adults, that wasn't really talked about. And we noted that even identifying an older adult with addiction issues is a challenge, because the presentation of someone who's impaired under the influence of an older adult could mimic a typical aging process: forgetfulness, falling, being deconditioned, being frail, okay? And so that's a challenge in itself. And then once substance misuse is identified, the next challenge in this population is getting them to treatment, the referral process. And if the family is successful in referring their older adult loved ones to a treatment, and then we take over, right? We take over, and then first order of business always, not just older adults, but for anyone who comes to a facility like this, is proper, safe, comfortable withdrawal management. And older adults needs that too. The number one substances of misuse in this country in older adults, still alcohol, followed closely by prescription opioids and benzodiazepines. Now, we do see illicit substances, but not as much. So to successfully manage an older adult for withdrawal management, we have to understand pharmacodynamics and pharmacokinetics. Basically, is what the drug is doing to the body and then what the body is doing to the drugs. Okay, that's basically what that means. So pharmacokinetics is what the body does to the drug once it's inside the body, whether that's our medication that we use in detox or the substances that the older adults are taking. What are their body doing to that substance? So one of the most important things is this first pass metabolism. That really has to do with the liver. Okay, and even everything we put in our body, virtually every substance, the liver is like a big giant filter. It takes that substance out of the body, it processes it. So when we talk about alcohol use, okay, we all know that if one drinks long enough and in large amounts, it's going to affect their liver. Their liver is going to be damaged. Therefore, the liver is not going to do its job, able to process that substance. Now we got a problem, okay? Not only the substances that they're using at home, but also how we manage their withdrawal. We're using drugs, some powerful controlled substances. And also the drug distribution. What that means is that once a substance enters the body, how is that distributed in the body? Where is it going to? With an older adult, that is very different, okay? Compared to a younger, perhaps healthier person. I'm an anesthesiologist. I used to be the chief of pediatric section at Nebraska, and I take care of babies and children. And what I used to tell my residents is that we treat older people like we treat babies, okay? Because the vulnerability to substances is very similar to a baby. They're very vulnerable, very sensitive to any substances that enters their body. And the volume distribution is partly to do with that, because with an older adult, with the changes that comes in older adults, that drug distribution is affected just by the virtue of their physical makeup at that age. A 70-year-old person is not the same as a healthy 20-year-old. And the distribution of the drugs is going to matter because it's going to determine how much drugs are available to affect that person, especially that person's central nervous system. Protein binding is another factor that we consider in the human physiology. With an older adult, Sharon said earlier that there's malnutrition, right? And there's going to be reduced protein binding in that older adult. Okay, I don't want to go into a lot of details on this, but just a global idea of what is happening within that older adult body. So with lower protein binding the body because they're malnourished, what happens is that any substances that they take, any drugs that we give in the detox unit is going to be more available, right? Because there's lower protein binding so that there's more drugs available. So what that translates to is that whatever amount of drugs that we give them is going to impact them more dramatically than a healthy, let's say 20, 30-year-old person that has no issues with protein binding. And albumin's the same way. Albumin's the most abundant protein that we have in our body. Someone who's a drinker, for example, their liver's going to be affected. The level of albumin is a function of the liver. Okay, so when the albumin level is very low in someone with liver disease or maybe end-stage liver disease, that albumin level is practically non-existent. What that means is that any chemical, any drugs that we put into this older adult body is going to be very readily available. There's going to be abundant amount of that drug available to affect that body. And that's a problem for older adults. Drug clearance is another issue. Drug clearance is a function of the kidneys, how the kidney clears a certain substances. Oftentimes, the liver will process the initial compound or the initial drug. It breaks it down to subsequent metabolites, and some of those metabolites then are cleared out by the kidneys through the urine, right? And so if the older adults have reduced renal function, then that presents a problem. Now you got a backup. The liver processes the substances, breaks it down to some metabolites, but the kidneys can't get rid of it. This is a huge one right here. Heart function. Whatever we put into the older adult body or whatever the older adult takes on their own, it doesn't depend on one organ system. It is multitudes of organ systems that determines what eventually happens to that substance. Not just the liver, but the heart function as well. Because the heart is required to pump the blood through the organs, right? To the liver, to the kidneys. And if there's cardiac impairment from, let's say, coronary artery disease, or more commonly that we see in this addicted population is congestive heart failure. When they're drinking every day for 30 plus years and large amounts of alcohol, it's going to impact their cardiac function. They may encounter congestive heart failure. So what that means is that the cardiac output, how the heart pushes the blood around the body is impaired, okay? So that's gonna determine the amount of blood that goes to the end organs, the amount of drugs that can be carried to those organs to be processed. So you follow me on that, right? You got a poor pump that sends blood out to these organs, which carries the substances and the drugs to those organs. So there's a thing here called drug clearance, okay? The clearance by the liver depends on the blood flow, okay, to that organ and the extraction ratio. And that extraction ratio is dependent on the metabolizing capacity of the liver and the extraction ratio. There's an increase in the extraction ratio, then the clearance is rate limited by perfusion. Now, I put this down, and this is one of those examples of very dry topic. And the reason I put this down is to show how these organ systems are intertwined, okay? And the blood flow is involved, cardiac function, and the extraction ratio, the liver, and clearance, the kidneys. So they're all interrelated. And the reduction in liver blood flow in aging will mostly affect drugs with a high extraction ratio. So any drugs that requires a high extraction ratio and you have a sick liver, then there's going to be a problem with getting rid of that drug. That's the whole idea I'm trying to transmit here, okay? And again, reduction in the kidney function, renal function may affect metabolized drugs, which is what I said earlier. If the liver happens to be able to process and metabolize certain drugs, breaks it down to its components, if you don't have good renal function, then the body cannot get rid of those metabolites. So pharmacodynamic, so what we talked about in the last several slides of pharmacokinetics, what the body does to the drug. Pharmacodynamic is what the drug do to the body, okay, once we take it. And the magnitude of the effect of that drug depends on receptor of the target organs. Now, again, this is a very dry slide, okay? The message I want to transmit to everyone, again, going back to babies versus older adults, sometimes how the drug interacts with that body is very similar to a newborn baby, okay? And one of the most vulnerable one of the most vulnerable organ system is the central nervous system. That's a very, very vulnerable organ in older adults, just like babies. And the reason for that is the central nervous system in a baby is not mature yet. In the older adult, it has lost some of its integrity. In other words, protective factors. And one of the things that kind of breaks down as we age, and I'm getting there too, I can sense it, okay? And it's the protective factors in the central nervous system that has broken down a little bit, so it is more vulnerable to fat-soluble drugs. Okay, virtually every drugs that we know are mostly fat-soluble versus water-soluble. Okay, fat-soluble drugs, which is basically dope, opioids, benzodiazepines, pretty much everything. Fat-soluble drugs crosses through the blood-brain barrier very easily. When the central nervous system is at the optimal, okay, it confers some protective factors. You know, it serves as a barrier, okay, as a shield. But when the blood-brain barrier breaks down a little bit in older age, then these fat-soluble substances could cross through over it very easily. So now we got an older adult who's taking prescription opioids and benzodiazepines at home, and alcohol too. And it's crossing over that blood-brain barrier very easily. So what that means is that little bit goes a long ways. A young person may be able to take handfuls of oxycodone or Xanax, and it may not affect them like the older adult. Older adults, they take a little bit of oxycodone and Xanax and lights out, right? All of a sudden, they're on the floor and not breathing. That's a function of that blood-brain barrier. So central nervous system is rather impaired. The vascular system's the same way. We talked about the propensity for deteriorated heart condition, congestive heart failure. The lungs, many older adults have lung issues. Maybe they're long-term smokers. Maybe they have COPD, emphysema. And musculoskeletal is the same way. Musculoskeletal is an organ system, okay? Muscles, tendons, ligaments, and that is very, very much affected by especially alcohol use, okay? And how substances affect, especially alcohol, affects the musculature is that it impairs the protein synthesis, which is required for muscular integrity. So what older adults in our experience and across the country as well, this is well published, that older adult with heavy regular alcohol use experience what's called proximal muscle weakness, okay? No weaknesses up in the upper extremities above the waist, but very weak below the waist. So that's why we call it proximal muscle weakness. It's a peculiar phenomenon in that while they're drinking alcohol, seemingly they're doing okay. They could still walk. Maybe they fall more frequently and trip more frequently, but they could still walk. They come to us here, get admitted to detox, and alcohol use stops abruptly, and the next day they can't even get out of bed. Okay, they got wobbly spaghetti legs, and that's proximal muscle weakness. Renal function and GI system, again, these are organ systems that's impacted by their substance use. So all the substances, whether it's alcohol, whether it's drugs, streets, or legitimately prescribed drugs, all interact with the receptors in the central nervous system. Then this is an animated version of brain cells, okay? What's going on inside the brain cells. The red portion is the dendrite or the projections from one brain cell. The yellow part is the dendrite of the cell next to it. The green triangles represents neurotransmitters. They're like dopamine, right? We all know dopamine. Dopamine, serotonin, norepinephrine, gluten, we have lots of them. The green V represents receptors. They're made for each other. So for any physiologic function in the human body, whatever we need to do, for example, making a fist, I need to have my muscles contract and then relax. A process like this occurs in the brain that's responsible for that function. It's the motor cortex area on top of my brain here. And so once that process occurs, it allows, it initiates a cascade for this to happen, okay? And, oh boy, we can't see this very well, but basically what this slide is demonstrating is the part of the brain called the mesolimbic system, is the midbrain, the primitive brain. And again, this is all within the brain, within the central nervous system. In older adults, just like younger people, this mesolimbic system, the reward area, is in play for when we talk about substance use disorder and addiction. And it's a survival brain. So just like younger person, an older adult, whether it's illicit substances, alcohol, or prescription medications, it targets that mesolimbic system. And when this area of the brain is exposed to that substances long enough, even if it's a legitimately prescribed substance like opioids and benzodiazepines, that mesolimbic system is adaptive, okay? You'll adapt to that condition so that even this older adult, even if he does not think that he is abusing this medication or he doesn't consider himself a drug addict, right? He becomes dependent on that medication, dependent on that drink, just like a younger person. And it's not unusual for our older adult population here at Caron, Pennsylvania to come in and they truly believe that they are taking their painkillers and benzodiazepines by prescription. And later on, when their head clears up a little bit and they admit that, yeah, I kind of like taking that. It feels good. And so I take it to numb. I take it to lift my mood, okay? And then a younger person, that'll be like getting high, right? It feels good. And older people, it's the same way, but they just don't define that the same way. And that's a function of the mesolimbic system. So that's the oh wow area. It feels good, so I'm gonna take some more of it. I'm gonna have a few more drinks, right? That's the mesolimbic system. Not much different from older adult, but older adults, they will just explain it a little bit differently, that's all, right? And the older adults, just like the younger person, not just the mesolimbic system, that midbrain involved, which is sort of an addiction center, but their prefrontal cortex, which is our forebrain here, is the executive functioning part of our brain, eventually becomes involved also. And so when the prefrontal cortex is involved, that's when the preoccupation start to come, the obsession, the cravings. And older adults have that too. They still have a pretty intact prefrontal cortex, even though, you know, they may have some brain atrophy and become more forgetful. So the central nervous system, this is, again, going back real quick on the brain. There are many changes that occur with chronic exposure to mood-altering substances, especially alcohol. There's an increased cortical CSF, cerebrospinal fluid in the gray and the white matter. The numbers of synapses decrease. Synapses are those connections. Back in that animation, that slide, those connection between the cells, that's called synapses. And changes in the gray matter, eventually leading to more sensitivity to alcohol-induced damage. So this slide basically just to show that lots of processes occur, okay, especially with something like alcohol, but it does not exclude prescription benzo and opioids too. Now, we all talk about the damaging effect of especially alcohol, because in older adults, like we said before, alcohol is still the #1 substance of misuse. And there's a term that I'm sure all of you have heard before, that wet brain, right? You've all heard of that wet brain with the alcohol use. And what that term really means is that it's cell death. The brain has been so damaged, okay? With the liver, we call that liver cirrhosis. With the brain, we kind of call that wet brain, which encompasses a lot of things, not only cognitive impairment, like Sharon had talked about before, but there's a lot of mechanism that occurs as the cell dies, okay? And also with prescription medications, opioids, and especially sedative hypnotics, basically benzodiazepines and sleep medicines. It's a huge contributor of the initial presentation of the older adults at home, okay? Earlier, both Sharon and I talked about identifying older adults with substance use disorder, with addiction. And part of the reason for that is that with alcohol, with opioids, with sedatives, or any potentially sedating medications, because of how vulnerable their central nervous system is, as well as all the other organ system, it frequently will cause sedation for one. They're tired, they're fatigued, they're sleepy. That may contribute to their fall in conjunction with their frailty. So they can't walk very well, can't balance very well. And again, as a function of the brain, when a person can't even balance themselves, okay, therefore causing more falls. And they can't remember. One of Sharon's slides mentioned that they can't remember sometimes whether they already drank or not, or already took their medications or not. Not only, we always talk about that blackout, right? Can't remember what happened last night. Even it's not the same as passing out. Not the same as passing out, but blackout, just can't remember. And when it comes to alcohol, especially benzodiazepines, it causes what's called antegrade amnesia, okay? That means that from the moment that substance is ingested, then it's lights out. It affects the memory, okay? Encoding of new information in that midbrain area, right below it, an area called the hypothalamic area. It kind of impairs the encoding of new information. So they can remember after they take that. In anesthesiologists, we knew about that. We use a midazolam, which is a short-acting benzodiazepines. Once we give that to the patient in pre-op, they're not lights out. They're still awake, but they just can't remember anything after that. They can't remember the conversation with the nurses in pre-op. They can remember the conversation with the surgeon after. That's why we can't give it until they talk to the surgeon, because they won't remember anything. Okay, so that's antegrade amnesia. Same thing happens at home with prescription benzodiazepines. There's also acute toxicity involved with some of these substances, and then tolerance develops, okay? Tolerance is one thing that most family members and friends and even medical providers don't understand when they're taking care of the older adults. Every human body will develop tolerance to some of these medications. It's a human physiologic phenomenon. You take something long enough, okay, and regularly enough, that body's going to develop tolerance. You're going to need more and more and more, okay, to have the same effect. But what happens when tolerance develops for quite a while is that the body potentially could go through what's called interdose withdrawal. Okay, that means that the body could begin to go through withdrawal symptoms even while that person is still taking that substance. So an example would be someone who's drinking a half a handle of vodka every day. He tries to cut back on his own to control it. So he's now only drinking a pint of vodka every day. He will be going through alcohol withdrawal, even though he's still drinking something. So that's interdose withdrawal. Same thing happens for prescription opioids and benzodiazepine. Older adults could begin to experience that. Now they're going through withdrawal symptoms, depression, anxiety, jitteriness, restlessness, confusion, and the family doesn't know what's going on. Is mom just getting older? Is that why she's acting like this? Well, potentially mom could be going through interdose withdrawal, and that doesn't feel great. So I'm going to stop right there, and Sharon's going to take over and talk about the rest of this. So hopefully all that wasn't too confusing. If it was, I apologize.
I thought it was great. How do I get rid of that? You're the queen of computers. So I want to talk a little bit about the contributing factors. There has been an increase in opiate use due to chronic pain conditions. 25 to 85% of older adults adversely are affected in their daily functioning due to chronic pain. And that's why we have a chronic pain track here at Karen. Very, very important. Most common issues are arthritis, back pain. Oftentimes we've seen people with knee problems, hip issues. And then older adults seem to medicate their pain and they want to, and they don't necessarily, as I said, maybe want to abuse it, but they become physically and psychologically dependent on the chemical. And then the greatest thing is the fear of getting off of those. How am I going to function? How am I going to do anything on a day-to-day basis if I don't have my medications? We treated a woman some time ago who never used a substance, never used alcohol or anything. At the age of 80, had a hip condition, and she just got hooked on it through a doctor, stayed on it for several years rather than months as it should have been. And we safely withdrew her. She did stay with us 8 weeks instead of the normal 6, which is recommended for older adults. And she left here, she engaged in NA, and she wanted to do anything she could to stay off the opiates because it was so horrific for her. So, and if it's left untreated, we certainly see the cognition decline and also heightened anxiety and depression. So now it's doing it again. So there's also been an increase in overdoses in older adults. Fatal overdoses in 65 and up have quadrupled in the last 2 decades. 13% intentional using prescription opiates and benzos. 83% unintentional. Synthetic opiates, heroin, cocaine, methamphetamine, using alcohol along with that, and then 4% of those undetermined. And as I said, many older adults, especially if they have co-occurring issues, have a tremendous feeling of despair, hopelessness, oftentimes loneliness as well. Trauma is another factor. When we treated the older adults, many of them had trauma histories, never looked at it, never talked about it, got busy with their lives, raised their family, had their careers or whatever it was. And then later on in life, when they're retired, too much time again on their hands, increased alcohol or drug use. When we did get them into treatment, we had no choice but to address that trauma with all the expert ways to do that, either EMDR, CPT, cognitive processing therapy. So it says 90% of older adults have had at least one trauma in their life, and some have past mental health issues as well. So it's almost like the perfect storm. Recent traumas can absolutely cause anxiety and depression. And it also increases, you know, stress is really, really bad for the body. And I've watched that over time with people when they have tremendous stressors in their life, it literally wears them out. The heart issues like Dr. Wang talked about, and stress exacerbates chronic pain as well. Trauma must be addressed in older adults. So I'll just show you this briefly. This is in your slides, but the continuum of care, as I said, has to be very individualized. Some go to extended care after inpatient treatment, if it's accommodating for an older adult. Outpatient levels of care, most older adults don't prefer to go to IOP, but they will be willing to do 1 or 2 groups a week or an individual. Sometimes caregivers are in the home when they first re-enter the home. Recovery coaches are excellent for this population, especially if you can get a peer-to-peer kind of thing going. 12-step meetings for sure, wraparound care, nursing homes if it's warranted. If someone has cognitive issues that are extremely impaired, then getting them into assisted living with memory care attached to that would be good as well. Well, we also found that there's a high success rate in this population because once they start feeling better, they want more of it. And they also do not want to disappoint their families anymore. Or I've had the most dear thing happen with this one couple where we do treat couples here at Karen. And the grandchild wrote Pop-Up a letter and said, please, Pop-Up, I want you in my life. That brings tears to my eyes. So it is absolutely never too late to develop an abuse or a use history. It is never too late to intervene on it and on any of the substances. And it's certainly never too late to have purpose and quality of life. People say, you know, when they come in here, you weren't having a good time. It wasn't going well. You were not living a quality of life. People say, why would you want, because we've treated 90-year-olds, why do you bring older adults into treatment? Well, why not? I know I want to live the best life I've got going from now to whenever it's going to be. So why not? You know, there's a term super aging, and super aging means that you're chronologically 15 years younger cognitively and physically. Harvard did a study. It's a whole other presentation I do. And there is a way to do that, but alcohol and drugs will never, never, never allow that to happen. And I always tell the patients, if you don't invest in your wellness, you will absolutely be forced to invest in your illness. There's no 2 ways around it. And I say that to you caregivers as well. We are all caregivers, period. So somebody said, I hate the term defying age. Some people actually live in strength, courage, creativity, and passion. And that is absolutely not about a date of birth. That's about a state of mind. And I hope that we can all embrace that today and transfer that over to the people that we're treating. So thank you very much.
Okay. Thanks, Dr. Wang and Sharon. I really appreciate your talk. It's very timely. It's a population that is often overlooked and we don't take into consideration much. So I'd like to ask for questions from the audience. I know I've got some brave folks out there. There has to be lots of questions. I have a question. I do. I'm curious with the legalization of cannabis, what you're seeing in older adults. It wasn't generally, you know, probably wasn't as common as it might be now. So I'm wondering if you're seeing increases in cannabis utilization in older adults.
Doctor?
The question is about cannabis, weed. And older adults, we do see older adults smoking weed, okay? Illicit substances in our continuum, we tend to see less older adults using the illicit substances. But some older adults will come to us with the miracle marijuana card, and some of them off the street. And cannabis, just like some of the other substances I mentioned earlier, they're fast soluble. THC is very fast soluble. So what that means is it'll cross over that blood-brain barrier and it'll impact that older adult brain much, much more, okay? Now, we tend not to see the complications of cannabis use in the older adult population compared to what we see here in the younger population where they're smoking THC all day long, every day. Okay, it's typically a secondary, tertiary substance to them, mostly for sleep. Okay, and sometimes I've seen them use it for chronic pain control.
For chronic pain is what I saw because I helped run the group, and that is when people would say, "But I was prescribed this. The doctor gave me." And I know I've had after we tell them, well, there's not that much research out yet to validate that this is really going to be good for you. Some will shred the card. You know, I've had people shred the card while they were here. So I think educating and giving the best options that we have, because the doctors have a really good way about doing that, interdisciplinary, using the ancillary such as acupuncture, medical massage, physical therapy. the wellness people come in and do the work with them. I think it's a better route for them, and that's.
Okay, I'm going to have to read this from the computer screen here. Okay, so into the mic. I have to read this from the computer screen. Okay, so thank you for sharing the statistics that 4.4 million older adults are living with a substance use disorder. I came across a recent statistic that approximately 1 million older adults are living with OUD specifically. This would represent over 1/3 of the nearly 3 million people in the US with OUD. I would be curious as to the speaker's thoughts, as I was quite shocked by this. Does this sound right to you? How does it compare to the demographics of the population presenting for treatment?
Now, the question is just specifically addressing opioid use disorder. And in the older adult population, that sounds accurate. And the reason for that, is you got to understand that older adults and opioid use disorder is typically prescription opioids. Okay, we're not talking about older adults copying dope off the street here. We're talking about prescription opioids. Okay, and the reasoning behind the prescribed opioids is typically for chronic management of chronic pain syndrome. And it's easy to prescribe opioids for pain. Very difficult to take that away. And so what happens is that in this generation, their physician might have started them on opioids for pain management 10, 20, 30 years ago, okay? And when painkillers were okay, right? And they continue on the opioids because it's even when complications start to appear, but it's very, very difficult to take that away, okay? So the easiest thing to do is continue to refill it until an index event occurs, a sentinel event. And what I mean by that, a sentinel event is something bad, something really bad happened. For example, the patient is completely confused and delirious, okay? Now they end up in an emergency room because of that. And perhaps the physician at the hospital discovered that, why is this 75-year-old person taking oxycodone for how many years? 25 years? And so that's when that comes to light, okay? And the family's scrambling around to find a solution. And the hospitals, a lot of times, cannot handle that unless they have a very, very savvy addiction medicine service like we have at Tower Health with Dr. Santoro. Most hospital systems cannot manage that because it's very difficult, especially older adults going through withdrawal management, okay? They encounter a lot of complications compared to a healthier population. So those numbers sounds about right.
Sorry. Okay, so the next question I have is, how do medical issues such as diabetes, heart disease play into the treatment of older adults? And then as a follow-up, how do you involve the family in treatment?
Will you take the medical stuff? I'll take the.
I'm sorry, what's the next question?
How do medical issues such as diabetes, heart disease play into the treatment of older adults?
Older adults have a lot of comorbid underlying medical conditions, heart disease, hypertension, diabetes. And when an older adult is, whether they're using alcohol or even prescription medications that's mood altering, it changes them, okay? The depression sets in, anxiety sets in, and lack of motivation to do anything. So they neglect their underlying medical issues. They don't go see their doctors, their diabetes out of control. So when they come to Karen here, we have to manage those as part of their care here, not just the upfront withdrawal management, that we've got to stabilize them from the cardiovascular standpoint, get their diabetes under control, and manage their chronic pain conditions. Yes, so there's a lot of that going on here on this campus.
And I would say the beauty of it is when the treatment is happening, when you see someone come in so compromised and when you see them 6 weeks or 8 weeks later and they seem to come back to life, it is the most marvelous thing to watch. And I think that's what keeps us all invested in really working towards a good goal with this population. As far as the family work from the Jump Street, first of all, they're very leery about passing their person on to us. We've even had people fly in here to see what the treatment looks like. Are you going to take care of them? Because they're absolutely fearful. They have lived sometimes in fear for many, many years. As I said, they don't know how to intervene on it. They don't know how to stop it. They've preached and hounded and whatever, tried to force them into doing something differently, which doesn't work. And then with the help of oftentimes an interventionist or maybe even a therapist, they get them to treatment. So there is tremendous relief when the family drops them off here at Karen or at any treatment center. And then we get them to focus on themselves because for years, maybe they haven't been able to focus. Caregiving is something that will absolutely wear any of us out. I've been in that role. I know it's tough. And that is how it is for the caregivers of older adult people in treatment. So we educate them a lot. We get them to focus on what they can do. So when they get eased into treatment, and there's a lot of phone calls, there's a lot of, in this population, a lot of staffing where we bring in the patient, the other disciplines, have the family on the phone and get everybody on the same page so they are hearing the same thing. And we try to give them hope, but we also are very honest with them. If things are not going along, like especially with the cognition, I had a person when I was helping in Florida recently that he was just not coming back, and it took a lot to convince her that this is how it is. And we recommended assisted living with memory care attached. She wasn't having it. She's taking him home. So there's a tremendous amount of education, involvement with the family. And then towards the end, they do pretty good while the person's in treatment. There's a lot of WebEx where we have family sessions, even if they're not here on campus. But then towards the end, their fear starts to pop up again. Oh my God, this person's coming home. Oh my God. And they also are oftentimes looking for guarantees, which we absolutely cannot give them. But what we can do is make a plan for not only the person, but also for the family member.
Thank you. I can think that that would be extremely complicated with people sometimes who might be invested in being taken care of. So they keep connection with family with the idea that if I get better, my family might not be there for me too.
Could be.
I'm just a thought. The last question is how do you, and this is probably a longer than 3-minute answer, but how do you identify cognitive issues from substances versus natural cognitive issues? Not natural cognitive decline, I would say.
Okay. As I said, when they first come into treatment, you really don't know what's going on, and we basically stabilize them first. So Dr. Daughtry does do a lot of testing. We start with the MoCA at first, the Montreal Cognitive Screen. 30 is normal, under 26 you're starting to be impaired, so she starts there. And then several weeks later, she retests them. Then beyond that, there are many other tests that can happen. The RBANS is one of them. She also has a dementia scale, but you cannot do any of that early on because you do not know if it's alcohol or medication-related memory loss, or if it is a start. I'll give one example. We treated a couple when they did the MoCA initially. He scored 14, she scored 2. And I knew from Jump Street, this woman was not coming back. She couldn't find the word. She couldn't articulate the word. She couldn't say the word. You know that thing over there. So I almost knew. So we retested her later. Her score did not move 4 weeks later. The husband's score came up a tad. So the beauty of that, the family was on board and knew that they couldn't manage this anymore. And they worked on assisted living where they could move together. And then that had memory care attached so she could move over. So it's a slow, steady process. There are many, many testings that can be done. I know in Florida, they do a lot of PET scans. They do so many, for even more testing, I think, than we do here in Pennsylvania. And it is, as I said, a slow, steady thing because you just can't jump the gun early on and diagnose something that may not be there. Okay.
Thank you. We need to take a 10-minute break, but let's thank Dr. Wang and Sharon for the presentation. Thank you. And we're going to take a 10-minute break, but we need to be back here promptly at 10:10. So back in your seats for the next one, coming live from Ireland. Thank you.